Assalamu alaikum everyone. Welcome for our faculty professional development series. Today I would like to welcome Dr. Prof. Mohamed Al-Eraky, who is our speaker today. Thank you for being with us, Prof. Mohamed. Prof. Mohamed is actually, he was invited from the Gulf Medical University. He is an associate professor and chairman of the Health Professional Education Department. Prof. Al-Eraky is originally a physician and he has master in medical education from Dundee University in UK, and he has PhD from Maastricht University. He specialized in faculty development of medical professionalism, and Prof. Al-Eraky actually he contributed to many planning and tutoring and assessment and supervision for students in master and PhD programs in many countries like Saudi Arabia, Pakistan, Egypt, UK, and even in Netherlands. Prof. Al-Eraky have a massive experience in medical education, and we are welcoming him today to be our guest and speak for us about the Concordance script test. Thank you, Prof. Al-Eraky, for being with us today. Prof. Mahi just joined now. I think also Prof. Mahi would like to welcome Prof. Al-Eraky.
Thank you.
Okay, Prof, you can share your screen, and please welcome in the University and College of Medicine.
Thank you very much, Dr. Awad, and thanks, Dr. Mahi, for the invitation.
Thank you very much.
Yes, Dr. Please.
It's really a great pleasure to have you here. And as mentioned by
Prof. Mahi, we cannot hear you well.
yeah, actually.
Can you? Yeah.
Can you hear me now? It's okay. Always
No, I think.
Zoom. Okay, I think I'd like to welcome Dr. Al-Eraky, and I think, as you have mentioned, he really has vast, great experience in medical education, and he has delivered script concordance tests to many international conferences, and he really is the best to talk about this topic, and we hope really we have more collaboration with him in the future. Okay, thank you. Thank you, Prof. Go ahead.
Thank you.
Thank you very much, Prof. Mahi, for the invitation. I'm very pleased to be here virtually with you, with colleagues at the University of UAE University. I know Prof. Mahi for so many years now, and it's a pleasure to contribute to the faculty development program at the university. And thanks, Dr. Awad, for the coordination. Now, this session is about script concordance test, but I would like to take the opportunity to discuss how we can expand our toolbox in assessment. So to take it just a little beyond the script concordance test. And as most of the session, they start by listing the learning outcomes. This is what usually is related to medical education, to start to decide or list the expectations of faculty members from this session and participants. So actually, for me, the first outcome is the most important one, that I would like you by the end of this session to use more tools to assess cognitive abilities of your students. That may include the learning outcome number 2, 3, and others. So having said that, the learning outcomes and the assessment tools, as you know that about the alignment between both of them. So it seems that the learning outcomes may look like this, and the assessment tools should fit with the learning outcomes. So you cannot assess something like in behavior using a written exam. For that, what are the tools that we have as assessors? And I would like each one here, if you don't mind, just to mention your role in assessment before we start, and then this is the toolbox. So are you engaged in assessment for your students? Of course, but are you also engaged in assessment committee at the college level or at the university level? So if you please, you can anytime use the chat box to interact with me. Can you write in the chat? Can you please check if it's applicable? Okay, and participants, they can use the chat box as well, because I'll be using it also to share some documents throughout the session, and also we might have an activity towards the end of the session. Okay, somebody else can use the chat box. With Mohi, of course. Participants, I hope that you don't. Okay, yes, Dr. Awad is in OSCE. So what is your role in assessment? You're planning OSCE, Dr. Awad? Yes, this is, please for the chat, use everyone, select everyone in the chat box so everyone will see your comments and your questions. And also you are using the questions. The chat box is disabled. Dr. Awad, can you please check the chat box?
Yes, I will. I will enable it now. Okay.
Okay. Now try it, please, Dr. Talal. Dr. Nadira is using Dusi. Okay, Dusi. Chat is still disabled. Can we have some technical support to enable chat box, because this is important throughout the session. We need to interact with you.
Can you enable the chat box?
Yeah, please. We have assessment box and we have chat box. I'm gonna start to do two boxes today. Okay. So there is an assumption that we use very few tools in written assessment for the assessment of knowledge. I'm talking knowledge ability, cognitive ability. And if this is our assessment toolbox that includes all types of assessment, all types of exams, do we use it to its full potential? What do you think? Yes or no? And if not, why? What is missing? And what are the tools that you wish to use, but you couldn't, or you need more training on that? Because skip concordance might be one of the usually overlooked tool in assessment. I think the chat box is still disabled. Okay, sure. You can write in the QA for it's enabled. Yes, hi, this is Dr. Awaz talking to you. Can you reply? Or if not, please use the QA until we fix the chat box, because I need your input in this question.
Question and answer is okay. The question and answer.
Question and answer is working, yes. Now it seems working now. Yes, now it's working. Excellent. Yes, wonderful. Okay, everyone, please select everyone in the chat box before posting, so people will see your comments. Or this for Dr. Mona. Okay, Dr. Aishan. Okay, so now this is the question. Do we use the full potential of our assessment tools? And guess what? Even MCQs. Today, we will see how we can expand a very routine common tool like MCQ. Is it expandable or not? So this is now why we need to expand our assessment toolbox. So we don't. Dr. Ayhan say no, we don't. Dr. Amiri, please type to the everyone, because now only the host and panelists, they see your comments. Assessment tools at times does not encapsulate the students' knowledge fairly. Right. Can you please elaborate on this, Dr. Lena, that how they not encapsulate student knowledge? I mean, there are hidden areas of their knowledge that is not assessed, or are, and that will take us to another question. Do we have to assess everything? Or can we assess everything? This might be unfeasible. Yes, exactly. It's unfeasible. But the point here that we need to select what to assess, what to sample in our exams. Right. So this session has two purposes, simply. We will learn how to generate many MCQs from the same question. This is one of the challenges for most of the assessors, that we have a limited number of items. In my capacity, I have maybe 200 items, 300, even 2,000 MCQs at departmental level, but students, they are now aware about almost all of them. So how I can generate MCQs from the current ones, which I will call it today item cloning. This is the first purpose of this session. And then the second one, discuss the utility of other tools to assess knowledge. Now, Dr. Lena is saying that some students do so well when asked during bedside teaching, however, do poorly in exams or not so well. Nice. That's a very good observation, Dr. Lena. And the point here, perhaps some people, they are, and could be the other way around also, Dr. Lena, that some of students, they perform better in the written exam as compared to the Viva or the oral or the practical ones. And it depends sometimes their preferences. Some of them, they are extroverts, they can express themselves, while others, they only can make written responses. And for you, it is not about their preferences. For us as assessors, it's about the outcome. Let me hold here for a second. If the outcome of the assessment, or the purpose of the assessment, is to assess documentation, so there is no point to assess this in a Viva. You need them to document and use the proper language, the proper system for information, hospital information system. So the purpose will dictate the tool of the assessment. While if it's more about communication and handling patients' queries and sometimes objections, so it's about communication. So this needs to be assessed in real practice, not in a written dialogue. So this is just a comment on Dr. Alina. You can use case-based MCQs. Yeah, they call it context-rich, Dr. Ayhan. Yes, context-rich MCQ with scenarios, and then you ask the question. But the irony, sometimes the scenario, you are giving a long scenario with so many details, and then you ask a question, so what are the common causes of dyspnea? Something like this. That sometimes the lead-in is irrelevant to the scenario. So you give too many details. So this is one of the common misconceptions or mistakes in developing MCQs. And could be the other way around, yes. Okay, so now we'll go back. So these are the two purposes of this. And start by the first one. This one, which item cloning. Forget about the term, because this is now, you may not find this term in the literature, but this is the idea about you want to clone many questions from the same one. So this is item clone. So let's say this is a scenario-based or context-rich MCQ. Here, just read the details here. Now tell me, what is the expected lead-in here? Please type in the chat box, what do you expect the lead-in to be? Okay, so you may ask, what is the most probable diagnosis? Okay, differential diagnosis, right? Like Dr. Moza, Dr. Talal. Also the underlying pathophysiology, so you go one step backwards, excellent. Or forward, best treatment. Or you may add a line in the scenario and tell them, if I administer this treatment, what are the expected prognosis? So I want you to think about the MCQ with this scenario like a timeline. And in this timeline, like this, there is a certain point, you tell a story, then you can ask something about what happened before that, the etiology, the underlying cause, the causative organism. So you can ask something backward, or you can ask currently what are the investigations before diagnosis? What are the investigations to be done? What is the likely diagnosis? What if these are the findings of the X-ray? So what do you expect? So it was diagnosed as pneumonia, for instance. And what is the treatment? So it was treated with this drug. Okay. What is the prognosis of this drug or the common side effects? So see, it seems like any scenario, like a story, it takes like different stages. And this is the way how you can think of the cloning of the question. And now I'll make it more explicit. Here, there is a scenario, like this is the anatomy of an MCQ. This is a very important slide today. There is a scenario, there is an event or vignette, and then there is a lead-in question. And after that, there are 4 options. One of them is the correct answers, while the others are distractors. There might be 5. And some researches that have been done to this, that 4, it doesn't make a big difference to have 4 or 5 with respect to discrimination. But let's say we have 4. So 1 is correct answer. The others are distractors. Now, the good MCQ, where you find the correct answer are close to the distractor, not too far, not too unlikely from the correct answer. So the more you'll find very proximity among the distractor and the correct answer, the more it's like, could be difficult, but also discriminating. Now, this is the structure or the anatomy. Usually, we start the scenario with a demography, like a 45 years man, old man or male. So you start by a demography. And then you give the context that it was admitted in ER, or it was operated last week. So you give a context, what happened and where. Is it an OPD, complaint coming to the OPD, outpatient clinic, or in the road traffic accident? So you give a context after the demography. And then the vital signs. What are the vital signs in this case related to respiration, heart, blood pressure, heart rate, and so on? Here you can fine-tune any of these. So this scenario, for instance, it's a 45 years old or year-old man. If it's like 12, would it make a difference? Yes. The expert will tell you that in this area, on this discipline, will tell you that there are common causes, for instance, in abdominal distension that are present in infant, which is like few months, as compared to the adults. So only if I fine-tune the demography here, if I fine-tune only the demography of the case, it will give a difference. See? Are you following here? Please let me know if I'm too fast or something. So, okay, so follow. Okay, thank you. With me, okay. On track, great, thank you. So, if you are only fine-tuning with the demography, you come up with a new question. So, the correct answer is not B, but actually it's C, because now this is an infant, not an adult man. The context, if it's an ER or emergency, or is something that is a cold case, somebody's feeling cough or a little dyspnea, discomfort. So it is not something urgent. That will give another dimension or maybe another question. The same playing with the vital signs, changing the vital signs. It's not hypertension, it's hypotension. So the students who actually remember the question from your sessions or from previous exams, they will rush to the B, because the B is the correct answer for them for that case. When they see a 45-year-old man presented to the emergency department with, okay, vomiting, okay, this is malabsorption syndrome or something. Okay, but if you just fine-tune any of these elements, the correct answer will be different. So see, now these are 3 points only to fine-tune, to come up with 3 questions now. Demography, context, vital signs. Moving forward, the clinical picture or the presentation. What is the common symptom? The common symptoms here could be related to painful groin, vomiting, colicky abdominal pain. What if the pain is not colicky, like stabbing abdominal pain? Now, for those who will read carefully, they will find the difference. So you only change the type of the pain, dull aching pain, not in the abdominal lower hypochondrial pain, something like this. So here you change it something in the clinical picture. So we come up with a 4th question. And if you change the history of illness, instead of 2 weeks, it is only last night, sudden. So again, it will take you to another differential diagnosis. Here, if you are asking about differential diagnosis, so these 5 points in the state, now we'll stop here with the 5 points. These 5 points about the case here, the scenario, will give a totally different dimensions or direction. Clear? Now, please let me know if okay, clear, great. Now, I will move now to the lead-in in orange here. I asked you about what is the lead-in, and then you mentioned something like could be the differential diagnosis, could be the treatment, could be the etiology. Here, the question will change the options. So here, if you are asking about what are the investigations to be requested in that case. So if they missed maybe ultrasonography, for now, this is very important, and this will make a clear diagnosis distinction. So here, this is the correct answer. Or perhaps if there is an important lab test, if there is something about the heart and they want to make an important lab test for that. So here you're asking about the investigations to be ordered in this case. Or you ask, okay, we have already ordered ultrasound, or we ordered the lab test, and we found there is a problem with liver functions. So what you say, we have ordered something, and then you ask about the findings. So you don't ask about the request, but you ask about the findings. What do you expect to find in the report? This is another lead-in. So 6 and 7, they are different leads in. And maybe you go backwards. What do you expect the pathophysiology or the pathogenesis or the causative organism, like Dr. Talal Yunus mentioned? And of course, the common one is the differential diagnosis. Usually we rush into the differential diagnosis, and students, they expect question number 9 or the lead in number 9. But we can use 6 or 7 or 8, 9 and 10. 10, what do you suggest as a management plan? It has been diagnosed as myocardial infarction. Done, khalas. So what is the management plan? And you give 4 other options related to management, not related to diagnosis. Okay? And then the side effects or complications. So we have already ordered this as a management plan. What are the complications or side effects? And finally, you can ask for the prognosis of the management plan. Okay, clear? So here, there are 12 different ways to have another question. Only by fine-tuning either the demography or the context above here, or the lead-in. So from 1 to 5 are related to the context. From 6 onward is the lead-in. Okay, so this is simple in one slide. How you can make item cloning, MCQ item cloning. So if you have like 60 questions, very precious questions, you can multiply them into maybe by 12 or by 10 to be 600. Okay, now moving forwards. Okay, expanding the toolbox. The important tool is the MCQ. Now, are there other tools? Yes, and this is the second part of this session, longer one, that we would like to discuss 2 different tools. One of them is a bit common, like the extended matching, and the other one, which is fairly not very common, the script concordance of today. So MCQ can be expanded, can be cloned, and then we move to extended matching. Extended matching is also known as the R-type questions or R-type items. MCQ is called with a single best answer. Somebody knows? The extended matching is R-type. So MCQ exactly as Dr. Rehan. It's the A-type. And the true false? Oh, okay, no problem. It's the X type. And the true false has a problem of probability. It's 50-50. So that's why it is not very recommended to use true false. Because MCQ, they have a chance of probability. If you have like 4 options, 3 of them are wrong. So to get the correct answer is 25%, right? Now let's see the extended matching. And is it superior to MCQ or not? And why? And why we are not using it? So extended matching with the R-type are multiple choice items organized into sets, groups, that use one list of options for all items. How is this? Let's see the anatomy. Now we saw the anatomy of the MCQ. There is a scenario, event, or vignette, followed by lead-in question, followed by the options. Here in the R-type, it's the other way around. The options or the answers, the possible answers, came before the scenarios or before the questions. So a structured extended matching or R-type will be organized in this order, including 4 components. The first one is a theme. There is a theme for the group of questions. Could be 10, could be 20 questions all together in one theme, and we'll see how. Then there is an option list of possible answers. Then there is a lead in and the series of stems, which are the actual questions. Now let's see a good example of R-type, and then I will show you other example, and you tell me what is wrong in these ones. Now, here is a good example of an R-type or extended matching question. There is a theme here up there. It's about fatigue. So you expect all of the options, which are the possible answers from A to N, not to D, A to N, to be all causing fatigue. They have the same common symptom. And there is a lead-in for each patient with fatigue that will be following. Select the most likely diagnosis. Here, you will give a scenario. Number one, it's question number one. And the answer here is E, which is Epstein-Barr virus infection. So here you give the scenario, and students, they have to select from all of the lists, any of the long list of options or possible answers. So that's a good example. Starting with the fatigue or the theme, followed by a list of options, all under fatigue. Then there is a lead in, and you can, this is one question, you can put like 20 questions. You can put 10 questions, and for each one, they will select one of the letters, one of the answers. Okay? More examples. Again, there's a theme, option list, lead in. Of course, all option lists, they are all congenital heart defects, as you see. So this question could be in embryology or anatomy or cardiology or physiology. And then after the lead in, you'll find question number one, question number two, question number three, and so on. For each question, for each infant with a congenital heart lesion, select the most likely diagnosis. So I will give the scenario, and students, they should skim all the full list of options and select the appropriate one or the most likely one. So this one E and this one D. So E is patent ductus arteriosus, and the other one is D, which is coarctation of the aorta. So these are good ones. Ready to see the not very optimum ones? Now, be attentive. What is wrong in the coming examples? Here. Excellent, Dr. Al. Yes. There is no theme. There is no common theme. Since there is no common theme, chances are that these options are not homogeneous. They don't lie into one category. Some of them are kidney stones, some of them are cholecystitis, colon cancer. So it's a mix of options because there is no theme. So this is not a very good example. Let me see, Dr. Talal. Dr. is saying that the abdominal pain is a theme. For hernia, J, torsion, yes. Endometriosis could be yes. Colon cancer, yes. And if this is a theme, Dr. Talal, at least you should put it up there. I mean, the assessor should explicitly mention the theme because, yes, kidney stone is there, ovarian cyst. Very good observation. So there is a common theme, but it's not mentioned, not explicitly mentioned. Why it should be mentioned? This is another argument. Why should I put a theme for the list of options? Keep it like this. Yeah, see, this is a question, Dr. Rehan. Is it a rule in R-type to write a theme? Let's argue why not. Why we should put a theme for this? test taker should discover. Okay, very nice. Here the argument that it's their responsibility as learners that they should see the common denominator, like Dr. Talal noticed that there is an abdominal pain as a theme. But are you assessing this, or you are assessing the differential diagnosis or the ability to select the appropriate diagnosis? Actually, it seems that you make assessing more accurate for Lena, yes, but here you are distracting the learners because you are assessing another thing. You are assessing like how they will find the theme among this. And this is not guiding. I mean, you want to assess their ability to put or label the right diagnosis or the right investigations. Can be used in any way. You can put a list of investigation. You can put a list of arteries in anatomy, a list of procedures in surgery. So you want them to match the appropriate procedure with the condition. And here, if you don't put the theme, I'm just continuing with the argument. If you're not putting the theme, they will be using their brains for another purpose that is not assessed, and perhaps not the purpose of assessment. And the more, they call it cognitive load on the learners. This is adding more cognitive load on the learners. That is unintended and only just for confusing. Okay? Adding one point from the assessor perspective, that when you put a theme, it's yourself, you are organizing things in one theme. So you can find a list of 10 options under one theme, and a list of 12 options in another theme. So come up with 2 groups of R types. Okay, but it's a very nice argument. Great. Yes, I know. In real clinical scenarios, there are no themes. And actually, there are other things. There are more complexity and ill-defined. That's why, Dr. Awad, in real clinical scenarios, you are assessing clinical reasoning. Extended matching is not assessing clinical reasoning as powerful as the coming tool. Remember, let me show you this one again. See this one. Here, you should be aware about what exactly are you assessing. In the extended matching, you are assessing matching the drug with the condition, or the diagnosis with the disease, or the clinical manifestations. You are matching things. But the point of clinical reasoning, we will use another tool that we'll be discussing today as well. It's descriptive concordance, the second one. Okay, so keep it for the next one. Thank you very much. Okay, now here you say that there might be a theme, and okay, you can put a theme up there, which could be abdominal pain. Nice, but look at this one. Why this MCQ is the R-type question is, what's wrong in this? Too much text, yes. And it seems like it's a fill-in question or short answer question. Something is motion sickness, have no effect on people, are completely, something like does not make sense. These are not options. These are sentences. There is no one dimension at all. Exactly, so here it seems like it's like a fill in the spaces or a short answer turned into an R type. So, and see also the questions, factors that people consider when evaluating air quality. So it seems it's like an English test more than, so you cannot use is a reduction F to answer number 1 because it's wrong. Or you can not use D, cause death, because it's wrong from grammatic point of view. So here, there is no homogeneity among the options. And that's the function of the theme. Okay. Now, when you use extended, this is when this particular tool is indicated. You know, like physicians, we're talking about indications and contraindications, right? So for education or assessment, when the R type or the extended matching items is really indicated, when you use extended, when you see a particular knowledge base or cognitive base, okay, I will assess this with an R type. When you have this note. And you said, no, I will not use MCQ for this. I will use R type. I think R type will perfectly fit into assessment of this. Questions with multi-dimension, right? Very close. But can you elaborate on this, Dr. Awad? I mean, what is multi-dimension? Like what? Can you please write your specialty here? Only mention your specialty so I can tailor the questions to you or tell you how to use it. It can be used for clinical reasoning. I don't mind. It can be used, Dr. Ayhan, in clinical reasoning. But when you see the next one, the skip concordance, you see, so this is for clinical reason. See, okay, psychiatry, Dr. Lena, medical education, Dr. Ayhan, okay, great. And there are too many answers, too many specialties. Dr. Aifat, public health, all right. Genetics, right. So for genetics, for instance, Dr. Amona, when you have a list of chromosomal anomalies, right? A list of 10 or 8 or 12 chromosomal anomalies, this is the indication of using R-type. Dr. Amal, pharmacology, when you have a list of drugs or side effects, okay? Now, this is it. Dr. Talal, oncology. So again, it's about perhaps the tumor markers, okay? You have a list of tumor markers that are diagnostic for particular cancers or particular conditions. So you have a list of something. Now, this is the answer. Whenever you want a student to select among a relatively long list of options, as in the following. So when you have a list of anatomy, for instance, arteries, nerves, or nerve injuries, muscles, amino acids and biochemistry, peptides, hormones, exactly, homogeneous options, molecules, lipids, organelles in histology, viruses in microbiology, cytokines, autoimmune disease, genetic anomalies, congenital anomalies, drug classes, any list that you have, most of specialties we do. Endocrine structures, cell types, blood components, of course, diseases, leukemias. So you have a long list, relatively long. I will not say, like, if you have a list of 5 or 4 or 5, so MCQ will be fine, will be enough. But if you have a list of 10 or even 15 drugs or drug classes, so here, this is an indication to use R-type. So in psychiatry, for instance, an example would be different mood disorders. Excellent. Yes, Dr. Alina, exactly. Different medications for the same family. Excellent. So here, you will list all options, or here options will be drugs, or could be disorders. And the questions will be describing the condition. So students or learners, they are expected to label which disorder is this one, which mood disorder is this one. from the above list. Okay, and the same for drugs or medications, of course. That's applicable for most of the specialties. Okay, so here, this is the true indication of using R-type. It's about listing and matching. Okay, how do we reconcile this? Question from Dr. Talal Yunus. How to reconcile this with the recommendation that in classic MCQs, we recommend use 4 distractors. You could have in vagina an MCQ with a long list of distractors. Here, Dr. Talal, the R-type, and we will compare the MCQ with the R-type, or the A-type and R-type in a moment. But as you see here, when you have a long list like this one, see, when you have a long list of conditions that may cause fatigue, you don't have this luxury in MCQ. In MCQ, you will have the question and you put for something. But if you have a dyspnea, for instance, could be a theme in respiratory or pulmonology. So dyspnea, and you put all causes of dyspnea. And then you start giving scenarios. For each one, they will label it. So it's just, bear with me. Next, we will discuss the comparison between the A-type and R-type. Okay? But just keep it this way, that whenever you have a long list again, that is not 4 or 5, you have a long list of 10 drugs. So MCQ, you will only get 4 or 5. Okay, but if you have immune disorder like 8 immune disorders, they are all similar, or not similar, they are all in the same chapter, that they are different. Or you have a list of viruses, bacteria, or infectious diseases, a long list. So this is like a candidate or an indication to use R-type. Now, Dr. Awad is asking a question. What do you think the answer? Is the number of options enhanced discrimination index? Yes. So Dr. Awad more eloquently rephrased my question. Exactly, of course. So the point here, the more, see again, this question here, how many? 1, 2, 3, 4, 5, 6, 7, and 7, there are like 14 options. So 14 options, I'm not very good in math. Let's say, let me count it, okay. What are the possibilities here? 100 by 14. So the possibility of having the correct answer in this list is 7%. In MCQ is 20 if it's 5 options, or 25 if it's 4 options. So discrimination seems to be much more when you have a long list. Getting the correct answer is much challenging than in MCQ or A-type. Okay, there is a question, Dr. Barati. Is there a minimum number of options for each stem? Very good question. We will reflect on some structural points related to R-type in a minute. But just let's get how to develop. Now you see the structure, okay? Now how to develop it, how to develop an MCQ step by step, or sorry, an R-type, okay? First step, you should have a theme. And this is for you as an assessor. So the theme will structure your ideas on the list. There is a chief complaint. The theme could be a drug class, could be a situation, could be mode disorders. Okay, you put the theme mode disorders. Okay, Dr. Lena? And then once you have a theme, one sentence, then you think about the lead-in. Are you looking for differential diagnosis? So here you will use this lead-in. Select the most likely diagnosis. So the lead-in indicates the relationship between the stem and the option. The stem will be coming. Okay, similar are the scenarios. Now, once you have a clear theme about the mode disorders, for instance, or drug classes, now you list them all. Put them all, relevant or irrelevant, before writing the question. And it's better to use it in a single word or short, very short phrase, 2 words, because that was the mistake here in this one. Here, it seems like half sentences. Some of them are too long or too short, like N, excess acute respiratory illness among children. What is this? This is not an option. This is a sentence. So for the options, list of options, they have to be homogeneous. They have to be better to be single word, only the drug class or the drug itself, and or short phrases, and list the option in alphabetical orders, unless there is another logical, like chronological order or ascending numbers or descending numbers. But it's better to list them in an alphabetical order, okay? Why you are listing them in alphabetical order? Now, this is the question for you. Now, keep it. I mean, I want the students to go and come and select. Yeah, make it easy to read. And see, these are listed in alphabetical orders, right, Dr. Awan? And these are also arranged in alphabetical orders in fatigue. To make it the same way, to make it easy to find, yes. Why it's make it easy to find? Because again, this is not the purpose of adding more extra cognitive load on students that is unnecessarily done. Here, you want students who know iron deficiency, for instance, they will go to J. I read this one, the answer is depression, for instance. So I will check for depression. Where is D? Here, D. It's not only about time. Yes, Dr. Ramona, it's about time. And also it's about adding an extra stress and cognitive load and processes for thinking that is unnecessary. That's why if they know the correct answer, they will go and get it. Hypothyroidism, they will go for the H. Where is the H? Hypothyroid, here. Okay, that's why it's better to put it in alphabetical order. Right? So here are the options. So you prepare the list of options, should be homogeneous and arranged. Now, once you have done almost half or even more than half of the job, which is very good news. You only have a theme, lead N, here's the theme. Okay, the set, lead N, could be antihypertensive drugs, for instance. So you put all the antihypertensive drugs you know, and then use the lead N. Select the most appropriate drug to treat the following cases. Then you put these are the options, all drugs. Sorry. Okay. So here the antihypertensive drug, then the lead N, then the list of all drugs or the list of all disorders or diseases. Now, these are the answers. Now you want to write the questions. Here it seems to be easier than the MCQ, which is another good news. Why? Because here you will look at the option C, and then you design a condition that is treated only by this drug, or a condition that is labeled by this disorder. Okay? And this is, of course, higher order thinking skills. Now, here you can develop 10, 12 questions in one set. You can spend like 30 minutes and then you can generate so many questions, because generate scenarios and you look at the answer and they have to get the answer from that list. Now, coming to your question, how many should I put? Let's see here. How many in the list? These are 8 options. So for these 8 options, how many questions can I create, or conditions or scenarios can I create for this 8 options? Maximum 8. Yes. It can be less, it can be 6. And you can expand this 8, you can add another 7, another 8 for other conditions, but should be relevant to the same defect. So let's say maximum 7, yes. Because, but it can be 8, by the way, Dr. Ayhan. Why? Because, can I say something? It can be even more than 8? Yes, exactly. This is the trick. If I can develop 20 questions for these 8 answers or options, how? I would need only to mention this clear line, sometimes in capital and bold, that each option can be selected more than once. Just write like this. This should be clearly done, because this is not assumed by anyone. Any learner, if he didn't write anything, if I look at a question like this, I will assume that each option will be used only once. So if I use iron deficiency once, I don't expect to select it again. I will remove it from the list, unless you clearly indicate before the lead N or after the lead N, somewhere with bold and sometimes capital letters, each option can be selected more than once. Once you put this, that means every time I will go for the whole list. That's why I can put 15 questions on these 8 answers or 8 options. And yes, and also you can put it, but it's assumed that each option is used only once. But otherwise, if you want them to use phthalate tetralogy or tetralogy of phthalate twice, and you will bring 2 cases, and the correct answer is phthalate tetralogy, that means you need to clearly mention. And it's of course recommended to mention anywhere that each option can be selected only once or more than once. So make it clear for students, because you want to minimize the stress that is beyond the target of the exam. Now, this is step number 1, theme 2, lead N, 3 options, and the questions, the items or the vignettes. Do you expect number 5? Yes, if it's actually that's a nice point also, Dr. Talal. If you have 8 options, okay, so the maximum actually should not be 7, and you will use only once. More than once, you can put 15 or anything. You can repeat the scenarios. But if it's only once and you mention it, you should, and for 8 questions, where is 8 questions? Now we'll put this other way. Now there is, if each option here can be selected more than once, you can go to 15, beyond the 8, 15, 12, anything, scenarios. But if they are used only once, what is the maximum? Only once. I would think 5. I would also think 5. Why 5? Because the last one, if I select A and B and C, 1, 2, 3, 4, then the 5th question, assuming that the question 1 will be A, correct answer, B, C, D. So question number 5, I will still have only 4 options. It's like MCQ. So I will have E, F, G, H remaining that is not selected. And each one will be selected only once. So the last question, to make it at least as the MCQ with 4 options, so you don't exceed 5. Thank you, Dr. Salah. You told me you're working in medical education, right? Is that clear? All right. Thank you. Now, this is the answer of the how many options for a question for the options. Now, once you write the items, then you administer the exam, or there is something. Something missing. What if after you develop the questions, there is one of the conditions that is applicable exactly? Thank you. Review. Thank you very much. Because you need to make sure that each scenario is only applicable to one option. So you give it to another colleague from the same department, from the same discipline, for instance, psychiatry or biochemistry or surgery, and ask him or her to select the correct answer. If she selected the same answer, that's fine. If she said, but this is applicable for H and G as well, or C and X or Y. So you review the scenario to make it only pertinent to one of them. So the review is very important step. This is number 5. Now, comparing the A type with R type. As you see, seems that the A type with many options has better discrimination power, because the likelihood or the chances, probability of getting the correct answer is much less than as compared to A, because you can go up from A to Z. A to Z, that means how many? Let's count it. 100 by 24. So 4% to get the correct answer. If I have the full alphabet, alphabetics for the long list of options for A up to Z. So that's a good news. There is another good news as well, that the R type can be scanned. Really? Yes, like the MCQ. So you can use, there are already forms, that OMR sheets, and now, of course, they are automatic. So you can get the correct answer as fast as the MCQ. The good news also from my side, that as you see the development, the more you are familiar with R-type, the more you will like it. But some people, they are becoming advocates of a tool. So when they like a tool, they use it everywhere. It's like holding a screwdriver and then you are using everywhere, or a hammer, and you want to hit anything because you like this R-type, so I'll use it anyway. So remember the indication of each tool, when to use MCQ and when to use the R-type. When you have a long list of options, so R-type is more appropriate. When you don't, so you can stick with MCQs there. How is it going so far? Any comments before moving on? And perhaps we can have a short break and then continue with the perfect, excellent. Thank you. All right, so I think let's have a short break, if you don't mind, and then we'll continue. Short break, like 10 minutes or so. And then we'll come back with the script concordance. And then expanding your toolbox with a new tool, right? Thank you. Have a break.
Thank you. Thank you.
Thank
You have stretching break, please.
Yes, stretching break. You can bring your coffee or something.
Okay.
10 minutes. Thank you.
Yes, shall we back to Mohammed,
Yes.
please?
Yeah, we're back. Thank you. Okay, so we were still expanding the toolbox, and so far we discussed the extended matching or the R-type and what are the indications for using this tool. And now we're moving to the title of the session, that the script concordance test. What is this title? Script concordance. Concordance means somehow alignment. So it's about aligning the hypothesis with the finding. How is that? Let's see. Script concordance, it's about how doctors think and troubleshooting, or even how engineers, how pilots, when they encounter a problem, they start by troubleshooting. Is it hypothesis A or B or C? So if you think about hypothesis 1 or H1, this is one of the hypotheses. Could be a differential diagnosis. Then you look for something or a finding to confirm your hypothesis. That's why in the history taking, there is somebody who tells you, I have pain in the right hypochondria. So suddenly, by experience, you come up with 3 or 4 possibilities. And now you ask a question to rule out one of them, another question to rule out the second. And then you're left with 2 you cannot differentiate in the history. That's why you ask for an investigation or MRI or ultrasound to rule out the last one. I hope life would be that simple, but actually there are so many underlying variables. So here, like you mentioned earlier, this is dealing with uncertainty. Script concordance is one of the perfect tools to assess clinical reasoning skills and reports students or physicians or interns' ability to interpret clinical data under conditions of uncertainty. When you are not sure, you cannot confirm or swear that this is, for instance, liver cirrhosis, or you can confirm this infarction, or you can, most probably you say like this, up to 90%, up to 80%, but it's not conclusive. That's why there is an element of uncertainty, which is part of the common practice in clinical practice. Now let's see an example how to use script concordance. I made one slide again to clarify the concept and give you an example of how to use script concordance, not from clinical practice, but from family household practice. So let's see this one. This is a condition of uncertainty, but somehow it's personal uncertainty. You are coming home late at 1 a.m., which is considered late. So there is a hypothesis and there are findings. Now, your job now is to think if the hypothesis is confirmed by the findings. That would mean plus 1, plus 2. Or no, the hypothesis is not at all in concordance with the findings. That means minus. So what about the 0? When you select the 0, if it's aligned, it's plus 1. If it's really confirmatory, so it's plus 2. If it's can be ruled out, it's not in alignment, not in concordance with the hypothesis, so it's minus. If it's totally exclusive, it's minus 2. What about the 0? When you may select 0, what do you think? Can you put in the chat? Exactly, when it's not relevant. So when there is there is something that the patient is telling you, but I had this breakfast and I went home, then I forgot my keys, then I went back. So these are all information, but they are totally irrelevant to the condition, the cardiac condition. But it might be irrelevant for people working in psychiatry because it seemed that there is something perhaps in the personality or behavior. Okay, so you decide based on, so it might be also relevant. So 0 is selected when the findings are not related to a hypothesis. Now I'll give you a couple of examples so to clarify and to demonstrate what I mean. Now, we are in the same condition. I saw you are coming home late at 1 a.m. And then if you were thinking, which is the hypothesis, everything is okay. So what? 1 o'clock, so fine. I mean, everything will be fine. It will be a nice. And then you found 16 missed calls from home on your mobile. So do you think everything is okay? Is confirmed? Or this finding is not really aligned with what you think? Let's say -1, Mr. Ahan. Yeah, perhaps you they want to, yeah, -1. It's not conclusive. No wife issues. Let's see, there might be coming, Dr. Awad. So at least it's minus. Now we agree it's minus. -1, -2, but it's minus, Dr. Amuna. Okay, fine. Now, could be -2, yes, because 16 missed calls. I mean, you should have attended to them. It would not be okay. Yeah, okay, let's keep it -2. Now, the second one, and if you were thinking that you will find dinner, this is a thought came to you, come 1 o'clock, no, but I may find dinner. And then you find there is good smell, good food smell. So is it aligned or not? Positive or negative? You find dinner, and then you find good food smell. -2. Well, 2, let's keep +2 if you see the food, because good food smell, it still smells, so it might be from neighbors or people, they just finished dinner and it's too late, still 1 o'clock. So let's keep it +1, everyone. So it is not 0, it's not minus, it's plus, but keep it 1 because it's not conclusive. It's still a smell. When you see food, you go and then you find food there and on the table. Now you will find dinner. It's confirmed, conclusive. So can we keep it? Okay, keep it +1, but we agree it's a plus. So question number 1, which is a question, the answer is minus because it's not aligned. But number 2, it is aligned somehow, so it's a plus. Now let's see number 3. Now, if you're thinking that your daughter is still sick, because she was sick this morning and perhaps she's still sick, and then you find a big storm is starting. Is it aligned or not? Or irrelevant? Exactly. Dr. Alina, she put in the host and panelists, it's 0. Now here you select the 0. Now, my question, do you really need people to select 0 to put some questions with irrelevant findings to the hypothesis? Yes or no, and why? Remember, we are in a condition of uncertainty where you will get so many information from the lab, from X-ray, from patients, from families. Some of these, they are not either coming with or against your hypothesis. Actually, this is what you want to assess, Dr. Awad. Why? Because you want students to filter out irrelevant information. Exactly, it's about noise. Thank you, Dr. Awad. So it's about noise. There is noise around relevant information. And you want to rule out all irrelevant information. So here it seems like a very clear example, but in real practice or clinical practice, you will find so many there, but liver function tests or something that these are irrelevant to the condition here. So this is one of your objectives in the assessment, that you want to assess their ability to rule out noise, the noise cancellation in their brain. Exactly. So discovering irrelevant information are also important. Very nice discussion. Now moving forward, another question now with the wife issues coming. If you're thinking that your wife is waiting for you and then you found that the house lights are off, is it aligned or not? She'll be waiting for you. Lights are off. Plus or minus? See, you know what I expect that. Some say plus, some say minus. Minus, yeah, it seems to be minus, Dr. Awad. Therefore, minus is not waiting, unless Dr. Lina put plus here, because yeah, if lights are off, perhaps there is a surprise. Somebody will turn on the light when you open the door. So it could be a surprise. So it depends about how do you know about the situation. If it's happened before and you're used to this, the lights will be off, and then when you go inside, the light will be on. Then what makes you so long? Why you are late? And then they'll start the. She's gone to her parents' house. Ah, okay. See, now when you dig into the scenario, you'll know better. Thank you, Dr. Lida. Wonderful. Right. So moving forward. So if you're thinking still the same ill-defined scenario, there are no many details up there, not too much details, just giving you that you're coming home late at 1 a.m. And then it will be a quiet night. You think, yeah, like everything is okay. And then the house lights are on. So is it plus or minus? With or against the hypothesis? Quiet night, light on, minus, yeah. Yeah, Dr. Amal, yeah, agree. Minus, lights on. So why people, they are celebrating your arrival at 1 o'clock? So it might be minus 2, yeah, could be, yes, exactly, Geraldine. So the last one. See, this is plus or minus. You're coming home late, 1 a.m., and if you're thinking that your wife will be angry, and then you discovered, you think that she will be angry, and then you discovered that today that was gone was her birthday, and you're coming at 1 a.m. after the day is over. So turn around, yeah, that's a good advice. Plus 100, yeah. Some people plus 5, plus 10. It depends on the context again. But at least according to the scale here, it's plus 2. But in some situations, some families could be up to plus 32 and so on, because this is like you missed her birthday and coming late, and you can expect that the lights will be on and a big storm is starting, but inside. So no food smell. So here I try to demonstrate, perhaps in one slide, the concept of script concordance, that you start with an ill-defined scenario with not too much details, like somebody's coming to ER or something, and then you propose a hypothesis if you're thinking about something, and the finding is either aligned or not. And this, your guess becomes one of these 5 options. And the solution for this is here. The last one in some context could be plus 12 or 25, something like this. It depends on different families here. Now, I hope the concept is now clear to you about how this tool can be used. It's a very simple one. Seems to be straightforward, but it's a very powerful to assess alignment of the hypothesis with the findings. You think about something and then either to rule out or to confirm. And the script concordance is being used in major institutions, in top institutions like Mayo Clinic, and it has been used also for different contexts in diagnosis, in investigations, and in treatment. So, for instance, you'll find examples like this. This is for diagnosis. So here, as you see, there is an ill-defined scenario, not too much details like in MCQ, because you need to keep more details in the questions. Question number one, you give a hypothesis, and then the findings either with or against. So expert will tell you that episode of vertigo lasts for 30 minutes. Is it supporting this diagnosis or not? Or nullifying? And so on. For 2 and 3. So the question, this is a full question, number one. Where are the options here? If this is the question that you're thinking about, question one, the diagnosis or the hypothesis, and the finding either supportive or not. Where are the options? This is another one for investigations. You would like to order something, and then you find something. Is it aligned or not? Here, you would like to order something, and then you find something for treatment. Exactly, options are the numbers. So these numbers are actually, they are not actual numbers. They are like A, B, C, D, E. There are 5 options like the MCQ. One of them is correct. The others are wrong. Sometimes the correct answer could be C, which is the 0. That means irrelevant. So these numbers, they are not actual numbers, but they are indicators of alignment or concordance of the hypothesis with the finding. I wish that we could have a short activity here before going on. We still have some time, maybe. This is a Padlet. Please go through this, and then I will open it here. And you will find a form that we developed here in the master program of health professional education that for students to be used for developing script concordance items. So if you have access to this, and I will share it here.
Mohamed, send the link to all, not only for the panelists. No, actually,
yes.
send it to the panelists only.
Oh, sorry. Okay, sure. I'll send it to everyone. I cannot send it from my side here to everyone. Can you please share it, Dr. Awa? Because you're the host, I think. I don't find everyone here, sorry. Yes, thank you. Now, once you access here, you can actually download, like this is the gift for today. You can download the form from here. Once you download it, it's editable. So you will edit the form here. This is the form. You will start by writing a brief scenario. And by the way, you might write something about the something in clinical practice, or even something like I did in any context related to family or sports or anything. And then the first hypothesis is the first question. This is the first question here, as you see, is there's a hypothesis, findings, and either they are aligned or not. And these are the options. The options means A, B, C, D. One of them is only the correct answer. we usually ask students to fill up 5 questions. So 5 script concordance questions. You can come up with more, but at least 5 questions. And they indicate different answers. So for instance, question 1, the correct answer could be -2. The question 2 would be correct answer could be C, which is 0, and so on. So try to select, and this is the key for what do we mean by -2, -1, and so on. The point here, the difference between -2 and -1, that -2 is the hypothesis is almost eliminated. So it's totally, again, it's exclusive. When you find this, that means it's definitely, it is not this diagnosis. It is not this hypothesis. While -1 is like, it's not very likely, so it's less probable. And the same for the +1 and +2. +1, more probable. +2 is conclusive. Something, if we have here a hematologist, Hodgkin lymphoma, for instance, when you find the Reed-Sternberg's disease cells under the microscope, it is pathognomonic. It is diagnostic. So here you put +2. If not, so it is probable or like adding likelihood. So if you can download the form and then can you download the form? Just let me know. And you can keep it, of course. You can use it in your context, like to generate the script concordance after this session. Just let me know if you are able to download it or not.
Yes, you need to click on the 3 dots in the corner, and then there's download.
Yeah, excellent. So if somebody could download it, please let me know if it's successful. Apart from the host and panelists, because they might have different privileges. Okay, great. Now, I will leave it with you to download it and work with that. And then let me share with you a couple of reflective points on the use of script concordance, and we can have a discussion. But again, how is it going so far? Is it seems reasonable to you? Your comments or ideas, please. Okay, done. Okay, great. Now I leave it to you to have the activity. If we are in the same place, perhaps it would be easier also to facilitate and give you feedback on that. But still, you can develop a script concordance and send it to me so I can give you feedback on that. Is the scenarios ill-defined enough, or there are so many details? So you can just send it to Dr. Awad or Professor Mohi, and then or let me share with you, this is my email here. This is my email at GMU. So if you have any question or you'd like to share your filled format of script concordance and send it to me, so I give you feedback on that. Now, I want to end with a couple of points, the design features for script concordance. And I would recommend only one article, which is the EMI Guide 75, that is discussing script concordance testing. This seems to be 10 years ago, but still relevant. And this is like to tell you the full story of script concordance and how it can be used. Not in one slide like this, but this slide, like I feel I use it a couple of times, and I feel it's like easy to understand the concept and how it can be used. But the full story is in this article. Now, some of the design features for script concordance, what are the points? See, remember, in R-type, we discussed what are the indications for R-type, which was whenever you have a list of options or list of anything, list of arteries, list of conditions. Now, skip concordance, there are 3 key features that you need to consider. First one, the problem structure. This is different from the MCQ and the R-type, the A-type and the R-type. In both A-type and R-type, you need to give a comprehensive story or scenario, because eventually they would come with a disease or the diagnosis or the investigation or the drug. So you need to give full details. Skip concordance is different. Here you need to start with a very ill-defined, not well-defined, ill-defined clinical situations, which is more realistic in real practice because you don't get so much information, and sometimes you get also irrelevant information. So having said that, when you see here, seems funny, but this is just a very abstract scenario. You are coming home late. So keep it simple and abstract. Why is this? I think I kind of mentioned this a few minutes ago. Why do you use an ill-defined scenario or situation in skip concordance? Let me bring again the example here. To allow the range of options in the answers to be in concordance with the real. Both answers are great. Dr. Lena, yes. To leave space for more details later in the hypothesis, correct. And also, Dr. Bahati, that to be in concordance with the real life. Because real life, it's about, sometimes it's very ill-defined. You don't get all details. Somebody will tell you, I have dyspnea, I have pain, I have cough. And then you dig deep and try to reach why this is happening. So mimicking the real scenario will make it more ill-defined or abstract, and also more importantly, like Dr. Lena mentioned, to allow the range of options in the answer, to leave space for more details coming. So you can leave hypothesis 1, 2, 3, 4, 5, 6, and maybe 12 different hypotheses there. Also, Dr. Omar Bakush said that to test decision-making. Yes, this is about clinical reasoning that is the basis for taking a decision. Very nice. Thank you, Dr. Omar. Now, talking about the undergraduate and postgraduates, you find skip concordance is more appropriate for postgraduates because they are in clinical scenarios and in scenarios, but I don't think this scenario is related to any clinical practice, but still you can use it. Some of our fellows or participants who attended this lecture, they kept using skip concordance even in their daily life. That what if like this, and then I find this, is it aligned or not? So it seems funny that it can be used across different contexts. That means you don't wait for postgraduates. You can use it for undergraduates. But here it might be challenging for people to decide the difference between -1, -2, +1, +2. So undergraduate students, they might only be able to decide either aligned with or against. So for that, you may be working with only 3 options. So -1, 0 for irrelevant, and +1 for supported. Last one about scoring. There is no one single best answer. Usually here we are talking about ill-defined uncertainty. That means the scores needs to reflect how closely the participant's ability to interpret clinical data. In plain English, you need to validate the correct answer with an expert. So that's why, for instance, this one, you ask an expert in the field, is it -2 or -1 if it's not aligned? And you need a group of experts to give you that the correct answer is -1, not -2, because it's not exclusive. For that, the correct answer will be, if this is A, B, C, D, E, so the correct answer will be B only. The others are incorrect. But adding a little more complexity in the last one. If it's something that is aligned plus, and one of the students, they said, no, it is minus. Is it only incorrect or it's against the correct? Here, there is something could be wrong and something could be very wrong. So again, the scoring, you got my point? Particularly between the minus and the plus. If the correct answer is with or supportive or +1 or even +2, and you find students that they say, no, it's not, it's -1. So this is not only wrong, this is very wrong. This is the other side. Okay? Here, you may think, depends on the policy of assessment, to apply the minus or the minus marking. So you give less marks for people who are getting the other side. Okay. So to conclude, lesson learned. I hope that you will tell me what did you learn today, and you can just type one sentence or something that you have learned today, and then I will also tell you what I intended to say today or to explain. The important concept that we can and we need to expand our assessment toolbox, either by cloning MCQs that we currently have, okay, or to when to use the R-type or the list of options. Okay. Now the A-type and the R-type, we compared them and we found that perhaps the R-type have more discrimination power than as compared to A-type. And the more you are using R-type, whenever indicated, you will find it's easier because you think about the option and you are developing the scenario for the option, not the other way around. So people who are used to develop options for the scenario, they will feel the other, you feel different. And yes, Dr. Omran, that the point about the negative marking or the minus mark, it depends on the policy of the institution and assessment. It is not recommended as a general rule, but sometimes there are people who are going the other side. I mean, for patient safety, you may need to give like an alert to these people, or to for those who not say +2, they said -2. So, and perhaps the misunderstanding of the tool itself. One last step. It's nice to expand your assessment toolbox, but don't use a new tool for the first time in the exam. You need to bring the tool, either R-type, skipped concordance, or whatever, to the classroom, discuss it with students, and have rehearsal on the way of processing and the way of answering, the interpretation of the findings and the scores with students. So they will feel that, okay, now we are familiar with it. So I hope that you are now familiar with this, and thank you very much for your time. If you have questions or comments. Okay, question, can we give like part of the mark? For example, if the right answer is +2 and the students get +1? Yes, yes. That's why this could be an option, Dr. Awad, that you give the full mark to the +2, if the +2 is the correct answer. But what if they said -2? I mean, this is my argument, that would it be applicable to give an alert or to check about the misunderstanding? And it's nice to use this one, safe concordance, not only for summative, but also for the case discussions. So for any case, you can come up with scenarios like this. Nice, thank you. Dr. Lina Amiri, I will be focusing on trying to use the R-type question. I'm now more mindful and aware of the hierarchy of the options in terms of relevance rather than the right or wrong. Thank you very much. Dr. Barati learned the difference between A-type, R-type, safe concordance. Thank you. Thank you very much. Ryan, thank you. Thank you. Pleasure to meet you all. Dr. Mona, thanks for providing samples. Dr. Geraldine, do I pronounce it right? Dutch name, right? I have a friend from Netherlands, from Maastricht. Geraldine. Dr. Amal, thank you. Dr. Ali Sag. Dr. Ali, thank you very much for your time today. And what about the time allocated for each question? Okay, Dr. Al-Hadi. The best way to allocate time, the proper time for each question, either MCQ or R-type, is to rehearse the question with students and see how long they need to process it, because you don't count it on your fast processing as an expert. So it's nice to rehearse and use questions with them and then see how they are being used in informative exams or giving feedback on that. Because there is no fixed rule, Dr. Al-Hadi, for this, that 1 minute and 2 minutes and 3 minutes and something like this. There is no fixed rule in the literature like this. And Dr. Ayan should recognize face-to-face meeting. Most welcome. Okay, other question. The NS concordance testing, first very well with our initiative to focus on clinical reasoning. Actually, this is the tool for assess clinical reasoning, Dr. Talal, yes. We need to teach students first how to tackle these questions and actually to use it more often in your discussions. So instead of bring a scenario in a case, you can use the structure of strict concordance like I used here in that slide. And ask students, why don't you ask students to develop them? This could be wonderful, because when you ask students to develop MCQs, for instance, they will learn to develop these questions. So if you ask them to come up with different scenarios and hypotheses and findings that could be aligned or not, this is a wonderful learning experience, Dr. Talal. Okay. Thank you, Dr. Omran. Okay, Dr. Awad, I think we're time.
Thank you so much.
It was an informative session, and I really enjoyed your discussion and the interaction with everyone here.
Thank you so much, Dr. Mohamed, for the time. It was really very nice and interactive, actually. And this is, we make the benefit all of us. Thank you so much. And thank you for agreeing our invitation and accepting to be with us today. We learned too much.
My pleasure.
Thank you for everyone who has joined us and stay with us. And Prof. Mahi is here. Prof.
Thank you very much, Prof. Al-Eraky, for this very informative session.
Thank you very much.
You are not only telling us about the strict concordance test, which is the topic where we announce it, but also we touch on MCQs, how to increase our rank, which is also a challenge for us as well, and also the extended matching items, and all these really are options for us because we are really struggling with to increase our tools and have more validity for assessment, particularly in the clinical years. And I think really those tests which deal with high cognitive functions like STT and extended matching item, I think will be really better options compared to MCQs.
My pleasure, Prof. Mahi. Thank you very much, and see you in next events. Thank you. Regards to everyone.
Thank you. Thank you so much.
We also included the key features, those that also.
Thank you. شكرا جزيلا.
Thank you very much, Prof.
Most welcome. It's my pleasure.
Thanks.
Thank you. Assalamu alaikum.
عليكم السلام ورحمة الله.